Welcome to this podcast on ventilation perfusion matching. Ventilation perfusion matching is essentially the balance of distribution between gas flow and perfusion, or ventilation and perfusion. This simplistic drawing basically shows what's known as the three-compartment model. In this situation, inspired gases take one of two courses. They either flow through lung units that are perfused, in which case it's assumed that the ventilation perfusion matching is perfect, or they go through lung units that are not perfused, in which case they constitute dead space. The same thing applies basically for pulmonary blood flow. It either goes through lung units that have a perfect ventilation perfusion matching ratio, or they go through areas where there is absolutely no ventilation, in which case they constitute shunt. So again, this is the three-compartment model. Compartment number one is dead space, compartment number two is perfectly functioning lung units, and compartment number three is absolute shunt, that is perfusion in the absence of ventilation. When we look at the standpoint of perfusion, and unfortunately now I'm going to demonstrate yet again why I'm not an artist. This, by the way, is supposed to be a patient in the supine position. And the situation with perfusion is relatively straightforward. Blood flow always goes to the gravitationally dependent portion of the lung. It doesn't matter whether the patient is upright, supine, prone, it's irrelevant. Perfusion always goes to the gravitationally dependent portion of the lung. Ventilation is a little bit more complex, or at least it changes a little bit more. In this circumstance, what you've got is, with the condition of spontaneous ventilation in a supine patient, the curvature of the diaphragm is greater in the posterior, that is gravitationally dependent portion of the lung, than it is in the anterior portion of the lung. That's kind of intuitively obvious because you've got the weight of the abdominal contents that are pushing down and at the same time up, and so that weight is greater in this portion, the gravitationally dependent portion of the lung. So you've got greater curvature of the posterior aspect of the diaphragm. The end result of that then is that the ventilation is distributed preferentially to the gravitationally dependent part of the lung as opposed to the non-dependent part of the lung. So again, you've got good relationship between ventilation and perfusion matching. That was the circumstance in spontaneous ventilation. In the circumstance of positive pressure ventilation, that the diaphragm doesn't really contract, so you don't have the advantages provided by the curvature of the diaphragm. So what happens is that the weight of the lung and other contents of the thoracic space the weight is greater on the gravitationally dependent lung units than on the non-gravitationally dependent lung units. The end result is that the compliance of these lung units is less than the compliance of these lung units. And in this circumstance, then, ventilation is preferentially distributed to the non-dependent portion of the lung. So you've got an increase in dead space. You see this, and you know this because you know that, the dead space to tidal volume ratio, the normal dead space to tidal volume ratio in a patient breathing spontaneously is about 0.3, whereas the dead space to tidal volume ratio under the circumstances of positive pressure ventilation is about 0.5. Again, this is due to the preferential distribution of ventilation to the gravitationally non-dependent portion of the lung, while perfusion continues to be distributed preferentially to the gravitationally dependent lung. I think that concept's a little bit easier to view in the supine patient. That's why I draw it that way. But the same circumstance exists in an upright patient. Now, face it, realistically, we don't anesthetize very many patients who are either sitting or standing, but nonetheless, we spend most of our time, or a major portion of our time at least, sitting or standing. So the same thing applies. Here you see, in the circumstance of spontaneous ventilation, that this is the change in lung volume with a breath, and you'll see that there's a greater increase in lung volume in the gravitationally dependent lung units than there is in the gravitationally non-dependent lung units. Again, since, as with the other circumstance, perfusion tends to be preferentially distributed at the bases, you end up with better ventilation perfusion matching. Again, this is in the circumstance of spontaneous ventilation. When you look at it in the circumstance of positive pressure ventilation, again, it's basically the same as what you saw with the supine patient. You get a decreased increase. There's less of an increase in lung volume at the bases than there is at the apex. So again, since perfusion is preferentially distributed to the bases, but ventilation now with positive pressure ventilation is preferentially distributed to the apex, you have an increase in dead space that occurs as a result of that because of a worsening of ventilation perfusion matching. So if you remember, we talked about the three compartment model of ventilation perfusion, and this dead space then constitutes one of those three compartments of that model. This table shows the concept even in the lateral position. So what you see is that in a patient who's conscious and breathing spontaneously, the distribution of ventilation between the right lung and the left lung is essentially 50-50, and that occurs with a patient breathing spontaneously. Again, this is in the supine position, with a patient breathing spontaneously, anesthetized, or with positive pressure ventilation. Now let's look at the patient in the lateral position. If the patient is in the lateral position with the left side up, look and see what happens. In this circumstance then, with spontaneous ventilation, a much greater percentage of ventilation goes to the gravitationally dependent lung than goes to the gravitationally independent lung. Again, remember that the perfusion is going to be preferentially distributed here. Now look at what happens with anesthesia, either with positive pressure breathing or with spontaneous breathing, and that is this situation is reversed. You've got preferential distribution of ventilation to the non-dependent portion of the lung, okay, but you continue to have preferential distribution of perfusion to the dependent lung, an increase in dead space and an increase in shunt. Having looked at changes in position, let's look at a couple pathologic changes now. In this circumstance, you've got two lung units. Each of them have a normal compliance and a normal resistance and the same time constant, tau, for both lung units. So this looks at the change in lung volume. This looks at the change in lung volume over time. And what you see is that over time, the distribution of lung volume, the distribution of ventilation is essentially identical, and the change in volume is the same between the two lung units. Now we're going to look at a circumstance. Again, this is time and this is volume. Now we're going to look at a circumstance of an increased resistance. What happens in the circumstance of an increased resistance? Well, this dotted line, this dotted lung unit is the one that shows us the dashed line on the illustration. So what happens is that because of the increase in resistance, because of the increase in airway resistance in this lung unit right here, ventilation is preferentially distributed to the lung unit with the normal resistance, and there's less ventilation that goes to the lung unit with the increased resistance. But interestingly, the purpose of this arrow, and you'll see it in several of the other slides, is that if you hold inflation at this point, wherever the arrow is, the arrow shows the direction of gas flow. So what this basically says is that if you held ventilation at this point, then these lung units, instead of being here and here, this lung unit would decrease and it might be here, and this lung unit would increase in volume, it might be here. So you've got better distribution of ventilation, or more equality in distribution of ventilation between these two lung units. That's the theory behind the advantage of an inflation hold or an inspiratory pause with positive pressure ventilation, because if you held inflation at this particular point in time, you'd get more gas flow than going to the lung unit that had the increased resistance than you would have without having done that. This circumstance shows a lung unit that has decreased compliance. And in this circumstance, what you see again is that the diseased lung unit gets less ventilation than the non-diseased lung unit, but the change in volume at inflation hold is exactly reversed, because again, remember that the compliance of this lung unit is less, so therefore the pressure, the intraalveolar pressure in this lung unit is going to be greater than the intraalveolar pressure in this lung unit. So when you hold inflation, then what's going to happen is that gas is going to flow from the non-compliant lung unit to the compliant lung unit. This one shows a circumstance of increased resistance in this lung unit and decreased compliance in this lung unit. And as you might imagine, the circumstance is a little bit more complex. In this circumstance, the initial portion of gas flow is going to be preferentially distributed to the lung unit with a decreased compliance, because resistance is going to be more of a phenomenon, more concern in the lung unit with the increased resistance. But over time, then, that changes. This shows the distribution of ventilation and perfusion as they relate to West lung zones. We're not going to go through this. You know this well by now. Zone 1 is where alveolar pressure is greater than pulmonary artery pressure, which is greater than pulmonary venous pressure, and this then constitutes dead space. Again, this looks at the 3-compartment model of gas exchange, looking at essentially saying that all lung units fall either into the area of alveolar dead space, ideal ventilation perfusion matching, or shunt, true shunt, absolute shunt, in which case the lung unit is perfused but not ventilated. Now, in reality, that probably doesn't happen. There are going to be some lung units up here which have ventilation in excess of perfusion, and so they've got some amount of lung unit that could be construed as being dead space, and the rest of it is ideal alveolar gas. And similarly, there are going to be some lung units that have a decrease in lung volume, but they're not completely atelectatic. So as perfusion goes by, it will pick up, the pulmonary blood flow will pick up some oxygen from that lung unit and put some CO2 back in, but it's not enough. And this then constitutes what I frequently call relative shunt. But again, this 3-compartment model of gas exchange assumes that all lung units fall into one of 3 types: either dead space with ventilation and no perfusion, shunt with perfusion and no ventilation, or perfect lung units. And we'll see that come up in another slide here, a few slides down the road. This slide shows what we've been talking about before, basically the distribution of ventilation and perfusion at different heights. This is anterior and posterior. This is a supine patient. Okay, so what you see is that in the anterior, that is the gravitationally non-dependent portion of the lung, there is less ventilation and perfusion than there is posteriorly, where there's an increase in both perfusion and ventilation. We often think about it from the standpoint of the distribution of ventilation and perfusion as shown by the multiple inert gas technique. What this does is this basically looks at lung units with different ventilation perfusion ratios. And so one of the graphs, one of the curves is blood flow, and the other one is ventilation. And it shows that in a normal healthy patient who's got an arterial PO2 of 97, the ventilation perfusion ratios, or both ventilation and perfusion, I should say, are distributed around a VQ ratio of approximately 1, essentially ideal ventilation perfusion matching. Unfortunately, this deteriorates with age. This is the ventilation perfusion flows, again, with the patient. This time the patient's a healthy 44-year-old patient. By the way, this shows 0 shunt. When we talked about absolute shunt before, that is perfusion in the absence of ventilation. There is none of that occurs in a healthy patient. But remember I talked about relative shunt, which looked at perfusion in excess of ventilation. That's this area of the lung, okay, right in here. And you'll see that you've got a greater spread of both ventilation and perfusion at different ventilation perfusion ratios that occurs with increased age. This increase in this relative shunt, perfusion in excess of ventilation as opposed to absolute shunt, perfusion in the absence of ventilation, this increase in relative shunt is what causes the decrease in arterial PO2 that occurs with age. In this circumstance, we look at a patient with COPD, and what you see is that it's there's significantly greater amount of the lung at relative shunt than there is even in the healthy 44-year-old. Again, this is the circumstance in a patient with asthma. Again, you'll see that there's no shunt and that you've got a wider distribution of ventilation perfusion ratios. And in contrast, this is the patient with emphysema, which, by the way, it also is essentially true for a patient with a pulmonary embolism. What do you see here? With this, you see that there's a substantial increase in the ventilation of areas that have very high VQ ratios, that is, that are approximating dead space. And interestingly, you also have an increase in shunt, absolute shunt. Okay. This graph, this illustration looks at all 4 simultaneously, but there's really nothing different than what we'd shown before. This is the last thing that I want to show. This is called an iso-shunt diagram. It looks at the different shunt ratios or shunt percentages that occur in different circumstances. This is here just to show you what it looks like. What you've got is that there are several assumptions that are here. The assumption is that the patient has a normal hemoglobin, has a normal CO2, although not stated. It also assumes that the patient has a normal cardiac output. And what you see is that if the shunt stays at, let's choose a percentage randomly, 15%, what you can actually do is you can come around and you can estimate what the arterial PO2 is at any given inspired oxygen concentration. So if we said, okay, we're going to put this patient on 50% oxygen, then what we do is come up here, draw a line across, and you see that the patient's arterial PO2 on 50% oxygen with a 15% shunt would be predicted to be somewhere in the vicinity of, what is that, maybe 150? All right, that concludes this session on ventilation perfusion matching. Thank you for your attention, and have a good day.